Today I will be discussing artifacts and troubleshooting in urodynamics. So a well-recorded study is paramount for proper analysis and interpretation, as exemplified by a uroflowmetry on the left side and a urodynamics which visibly is well calibrated in terms of P vesicle and P abdomen and proper zeroing with the well recorded P det and flow. Now, obviously, many variables must fall into place for an accurate recording, be it catheters, be it their connections, or the transducers connection with the computer, and the computer's software's functionality. Many things like air bubbles, kinks, leaks, knocking, that is touching the transducers, loaded rectum, empty bladder, software and hardware issues can lead to problems with interpretation and recording of urodynamics. So in uroflowmetry, there can be problems of setup provision like artifacts due to lack of privacy or due to unaccustomed voiding position, or there can be cruising artifact that the male patient, is kind of playing around on the funnel. An ideal would be passing urine at one position in the funnel, which is not the hole. There can be kicking artifacts. All of us have seen that while recording the uroflow, the patient touches the transducer, and then there is a large sharp peak. Most of the softwares will have provision of cutting it off during interpretation. They can be squeezing and releasing artifacts. Many patients with BPH, it has been a common practice to find that they will squeeze their penis so that the urethra is filled, and then they will release it to feel more confident about the flow of urine. Now, in cystometry, if the initial PVS and P abdomen are zero, that is, the zeroing has been done to the bladder and the rectum, not to the atmosphere. So it can be considered as an artifact as per ICS guidelines. As long as, however, the pressure response is equivalent, it's not really an artifact, as you can see in this study. However, we go by ICS and we zero to atmosphere and then activate the organ, and we will get a baseline P vesicle and P abdomen which is higher than zero value, and the P det will be subtracted to be uh, zero. Now there can be cuff response is checked, and ideally it should be either there is no response in P det while cuffing, or there can be a small up to 5 centimeter of water, sharp bidirectional movement. This kind of bidirectional movement, or in the PDET during cuffing, or unidirectional movements are not acceptable, and we should look for any kinking or any air bubble in one of the channels. Cuff response unidirectional is generally seen when one of the one of the measurements, whether P abdomen or P vesicle, is not showing it properly. Like in this case, this patient had a patulous anal tone, and whatever we would do, the P abdomen would not show a complete transmission. So we had to accept this unidirectional small PDET movement. PVES may suddenly fall below zero with a flat line. It is obviously that the P vesicle catheter has come out. Similar thing happens in P abdomen. Non-responsive PVES, we can see in the first half of the graph, while flushing, it becomes responsive. So it is because of the air bubble. Similar thing can happen in the P rectum. On the left side, we can see there is no response in the P abdomen, but after flushing, there is a good response in the P abdomen, and it is because of the air bubble. Sometimes the PVES, even after flushing, does not respond. So generally common causes are whether the catheter is kinked in the bladder, or the bladder is so empty that the measurement hole of the P vesicle is abutting the urethral mucosa. So generally, we, while moving the catheter here and there, rotating the catheter, taking it out a bit, flushing the bladder so that it's filled a bit, these are the measures that you start having recording again, like in this graph you can see in the later part. Now, a good urodynamic study ends with a measurement, a cuff response, which should be measured appropriately in the P vesicle as well as P abdomen. However, many times when the bladder is completely empty, we find this kind of non-response. And like in previous slide, we will just do some movement and fill the bladder about 10-20 ml and we'll get a response. Now, pump tubing movement artifacts, in this kind of artifact happens when the pump tubing, which is a pulsatile flow, touches the P vesicle and the P abdomen tubing, and they move according to the pump tubing, and this kind of artifact is given. However, you can see that P detrusor is almost silent. Rectal contractions can happen because of many reasons like fecal loading, neurogenic bowel dysfunction, use of colonic stimulants, and they can sometimes complicate the interpretation. So we have to be mindful and check the movement of P vesicle graph and make our interpretation semi-manually. Rectal relaxation is a phenomenon sometimes happen while the study is going on. The rectum becomes relaxed and the baseline tone in the rectum, which is measured by the P abdomen transducer, is showing a reduction. And what is the interpretation? That the P det will be higher than actually it is, and we have to make interpretation based on P vesicle in this case. Then there can be movement artifacts. We can see that the patient was moved, so there was some knocking kind of artifacts in P vesicle, P abdomen, which was translated into the P detrusor also. Now, this is a rare phenomenon. I have not been able to answer it. That you don't see any deflection in the P vesicle, P abdomen, but suddenly you get some sort of a deflection in P detrusor. In EMG, this is a proper guarding reflex and relaxation during voiding. Uh, uh, Many times, and this is also a normal guarding reflex that overactivity is leading to corresponding increasing the EMG. Many times you will find this kind of situation that the EMG is responsive, that is during voiding there is a relaxation, but there is a lot of background activity in the filling phase, or this kind of spontaneous activity is not responding to anything, it is just going on its own. Then there can be knocking artifact that the patient has moved and one of the leads of EMG has moved. Now there can be physiological artifacts like in this young woman with pure SUI with a normal uroflow. When a urodynamics was done, she had spasm of the pelvic floor because of the catheter discomfort, which led to this kind of abnormal flow pattern, and even the SUI extent had reduced because of the pelvic floor spasm, and this urodynamic study therefore was considered inadequate. Then, as discussed earlier, in many situations we have to do manual override, like on the left side because of rectal relaxation, or on the right side because of the poor bladder compliance. Uh, this is another situation in which there is a knocking artifact in the Q ura. Unfortunately, the computer did not take it as an artifact, and it measured all the Qmax and the PDET Qmax based on the artifact. So in this, we have to be mindful and we have to do it manually. And actually, in this situation, now this is the normal. This is the actual where we should be measuring the PDETs and corresponding flows. Now, this artifact is very funny that the person performing actually put the wrong tubing into the wrong transducer. And this is a very interesting situation we published about 13 years back. And this, as soon as the flow was initiated, the patient developed flank pain and the pressure rose. So we did a immediate X-ray and found that the urodynamic catheter was actually into the left ureter, and the contrast was filling the piece. This was a case of radical prostatectomy, post-radical prostatectomy incontinence evaluation when I was in MSKCC. and we found this strange phenomenon. It actually happened because his bladder, the ureteric orifice was nearly at the anastomosis. So to summarize, we have to prepare this patient well, treat active infections, control sugars, treat constipation or diarrhea before the study, make the patient comfortable, insert the catheters with adequate lubrication, sterility, and dignity, flush channels adequately, and connect with respective transducer, and we hope for a good result. Apply common sense at all times. Thank you very much.